Hello, everyone, and welcome to our webinar, Navigating Your Ovarian Cancer Pathology Report. I'm Stephanie Blaufarb. I'm the Ovarian Cancer Program Director at SHARE. And before we start the presentation, I'd like to tell you a little bit about SHARE. So SHARE is a nonprofit organization that for the last 42 years has been helping people through breast or ovarian cancer by offering the support of those who've been there. SHARE offers many services, including a helpline, telephone and in-person support groups, and educational programs. All services are free of charge to participants. For more information, you can visit our website, sharecancersupport.org. So during this presentation, all participants will be muted. When the presenter finishes speaking, we will open up for questions and answers. So you're welcome to submit questions at any time throughout the presentation. You can submit them by clicking on the question tab on the control panel, on the GoToWebinar control panel on your screen. When asking questions, remember, the presenter is unable to give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and will be available on the SHARE website soon. So our speaker today is Dr. Tamara Kalir. She earned her MD degree from the University of California at San Diego School of Medicine and her PhD degree at Georgetown University. She did her internship and residency in pathology and has been practicing for 28 years, all at the Icahn School of Medicine at Mount Sinai, New York City, where she currently serves as Director of Gynecology Pathology. She also serves as Program Director for a specialty fellowship in Gyn Pathology, and is Course Director for the Sexual and Reproductive Health course for second-year medical students. She has been named among America's top pathologists and best doctors. Her book, Ovarian Cancer, Challenges and Innovations, is currently in press. All right, take it away, Dr. Kalir.
All right, well, thank you, Stephanie, and thank you for having me speak today. I hope you'll find this informative and helpful. Navigating your ovarian cancer pathology report. At the completion of our talk today, I would like that you would feel that you understand the components of the pathology report, that you understand how the pathology report is generated, and that you'll understand how your doctor uses the information in the pathology report in managing your illness. So, the pathology report, there are specific components to a pathology report, and depending upon which hospital you're at, the form might look a little bit different, but I'm showing you a generic report, the style at Mount Sinai Hospital in New York City. As I said, if you're at a different hospital, it might be a little bit of a different style, but the components will be the same. And the basic components of a pathology report are the following: identifiers section, a specimen source section, a clinical history section, a diagnosis section, an entity called a gross description, and then addenda. And here's a picture of the first page of a standard pathology report showing you, are you able to see if I point with the mouse, the little arrow here? Up on the top, you've got your hospital name, and then your identifiers will be this top section, which will have a patient name, medical record number, date of birth, as you could see, their physician's name and dates of procedures and things like that. Then we see an area here, it's called Specimen Source. All right, then we have an area here called clinical history. Under that is diagnosis, and then we'd have to turn the page to see the others, but we're going to go over each one of these things in a little more detail. Okay, so we have our continuation of our diagnosis on the second page here. Regarding the generic information about pathology report components, some hospital pathology reports may also have a section called a microscopical description, and at Mount Sinai we don't have that section, so you won't see that on this report. You might see it on someone else's report. And some reports may show a thing called a checklist, which is this piece right here where my arrow's pointing. It looks like a little listing here. It's sort of a little summary of the findings that were written above the checklist. And so those are some extra pieces that may or may not be seen on a report. And here's the last part of the checklist, and then that part that I mentioned to you before, the name of the pathologist is listed at the end of the written report. And then we see this next section I mentioned to you called gross description. And then at the end of that would be any other findings. So let's talk about each one of these components in a little bit more detail. Okay, so the first part of the report we said was the identifiers, and I've clipped out on the picture from the report the piece that had the identifiers. And as we said, the identifiers will consist of things like the patient's name, pathology case number. Every tissue or specimen that is removed from a patient comes through pathology, and we give a special number just to keep everything organized and straight and make sure that that your tissue specimen is said to belong to you, and we don't mix it up with anybody else's, so everybody gets a pathology case number, and that's this thing here called specimen number, and it has a number, the patient's age, medical record number, date of birth, the location of the procedure, the doctor's name, date of collection, date of receipt of the specimen in pathology, and the date of the pathology report. Those are all the things that we put in the place that's called identifiers. And again, the identifiers it's an important section because it's used to avoid mixing up things. A lot of patients have surgery on one day and all their specimens will come through the pathology lab, and we want to make sure, especially if the patient's had a number of tissues removed, we want to make sure everything is organized and matches up with the correct patient. So it's needed to avoid mix-ups and to ensure that the report gets into the correct patient's medical record and to the correct doctor. All right, so now let's talk a little bit about that specimen source section I pointed out. And again, I clipped this out of the big body of the report just to show that in this particular case, you see that, let's see, there were about 9 or 10 things that were removed from the patient whose report we're looking at, some lymph nodes and some other tissues. Okay, the specimen source then is a listing of the tissues that have been surgically removed and recorded as such in the operating room as dictated by the surgeon. So one of the circulating nurses will write down, as the surgeon removes the tissue and hands it to her to put in a little specimen container, he'll tell her what it was and she'll write that down. And when it comes up to pathology, we'll have one of our staff will type those out into the report. The specimen source is a documenting of all of the removed tissues, and usually these will be tissues that are diseased in some way, and if they're not visibly diseased, some other tissues such as lymph nodes may be removed for what we call staging purposes. Specifically, they'll remove normal-looking tissues if it's known that these are tissues that tend to get targeted by ovarian cancer and may show microscopic involvement. Okay, so that's a little information on the specimen source. Now, clinical history, which was that third component of the report that we pointed out, and I've clipped out from the report I showed you, that little section here, you can see it's headed as clinical history, and the history that's written here is malignant neoplasm of the left ovary. Basically, the clinical history is some brief clinical information that's provided by the surgeon. And the information is helpful to the pathologist or the physician assistant who's helping to process the tissues. And also it's helpful to the pathologist who's rendering the final diagnosis by viewing the tissues at the microscope. The next section that we mentioned is the diagnosis section, and again, I've clipped that out just to show you. The header is in bold letters here, diagnosis, and underneath that you see each of the specimen parts. We had A, B, C, D. They are labeled that way, and here they are labeled again as to what they are and then there's a little hyphen here, and then there's a diagnosis after that, okay? So these are the labels of the removed tissues in capital letters, and the regular print here at the end are the actual pathologic diagnosis. And the diagnosis is basically a assessment of the tissue, whether it has cancer cells in it, whether it's benign. If it is cancer, it's very important that the histologic name of the cancer is given in the report. So this part that I clipped out doesn't have the ovary in it, so we're not seeing that part yet. I think that's on the next page. But the diagnosis section will give within it, and not shown again on this particular shot here, but we'll have the name of the cancer, the grade of the cancer, the extent of spread of the cancer, and we'll also give the stage of the cancer. And all of these things are important for your doctor in thinking about next steps in management. So the diagnosis, and here's the second page actually, and you can see that specimen I here that's called left tube and ovary, all right? And here's the name of the cancer. It says ovarian high-grade serous carcinoma, and then subspecific gives the size. It says that the ovarian surface is free of tumor, and that the fallopian tube may have some intraepithelial carcinoma growing. So some details about the cancer here. And the diagnosis is generated by viewing microscope slides, basically, that are made from the gross examination procedure. That will be described below under gross description. I'll show you, I'll take you through the steps of how we do that. And the diagnosis that is made by using a microscope and looking at slides that are made from the tissues removed in surgery, okay? The diagnosis is generated by a board-certified pathologist who, depending on the institution, may be an expert, also called a specialist in gynecologic pathology. All right, and the next section underneath diagnosis section was the section called gross description, and here you can see I've gone below where the diagnosis was, and I've clipped out for you to see again that part labeled gross description. And basically the gross description is for each specimen removed. It's a description of the tissues that's made by either the examining pathologist or a pathologist assistant or house staff. It's performed in the pathology laboratory after it was received from the operating room. And here you could see, for example, again, they're giving you on the report, it'll state what the name of the specimen was, what they called it from the operating room, and it'll give you some size of the specimen, tell you if it looks grossly like what it was said to be. And when I say gross, when we say the word gross description, what that means is non-microscopic. Gross in pathology means that you're able to see it with your naked eye. You don't need a microscope to see it. So that's what that term means. The gross description is important because we are able therein to detailed descriptions of each of the tissues received from the operating room. Okay, and the standard components of the gross description for each tissue are its size, and there will usually be 3 dimensions: a length, a width, and a depth. Although, understand for things like a fallopian tube, which is a tubular structure, it'll be then a length and then a diameter. Tube diameter, for example, but generally there will be 3 dimensions: color of the tissue, consistency of the tissue, the way it looks from the external before we end up incising it, and the way it looks externally, and then what we call this cut surface appearance after we incise into the tissue to examine how the inner aspect looks. We'll describe that as well. And then there usually would be statements about whether there's any hemorrhage or edema in the tissue or necrosis. Those are standard things that are mentioned in pathology reports. For organs or portions of organs that were removed, statements may be made as to whether they appear normal or whether they seem to be involved by disease. And if they do seem to be involved by disease, some detailed descriptions of how those areas look. At the end of each section for each tissue component, there's a piece called Summary of Sections, and that states how many pieces of tissue were cut for microscope examination, and that helps us to keep track of, making sure we get everything that was cut. And I'm going to show you how the cutting translates into a microscope slide very shortly. We just want to finish up going over the pathology report components, and then we'll see more details about how that works. The last section of the pathology report, after the gross description, there might be something called an addendum, addendum 1, addendum 2, and those basically are just if after the report was generated, there were any extra studies that were done, any extra work that needed to be done, follow-up studies, follow-up tests, that we would do those and then put those into the report in the form of an add-on. So they're called addenda. And as you could see on that part I, that left tube and ovary, we actually we thought we saw something in the tube, and so we did a special stain. And when that stain was done in the lab and came out, I was able to go back and make a little report on that at the end of the report as an addendum. So those are the basic components of the written pathology report that you would see in your record if you happen to want to review it. And so we mentioned that your tissues are removed in the operating room. They're transported over to pathology. We take a look at them, and then we end up getting some slides that we look at under the microscope to generate your report. So that black box piece was from the tissues getting to pathology, and then somehow the pathologist generates a report on. So I would like to show you how that happens. Okay, so we're going to look at some details of how the pathology report is generated. So again, we started with tissues being removed at surgery and labeled with appropriate identifiers. The tissues are transported to the pathology lab. Now, once in pathology, the tissues are assigned a special pathology case number. Again, this is for good record keeping, not to mix anything up. And everything is processed according to specific written protocols. And the processing itself will be described in more detail in the following plates. But again, the processing culminates in the production of a set of glass slides for microscopical examination and generation of the pathology report. So what are the steps in generating, again, the pathology report? And what I just said, here's a little schematic that's close together. And again, we mentioned that the specimens are start at the left here. Specimens are brought up from the operating room. Each specimen gets a special pathology number. And then we go to a prep station where the gross description is performed and the tissues are cut. Okay, and those are put in a special little device, which I will show you. They go through an embedding procedure, microtomy, staining, then issuing, and finally reporting. So I'm going to show you specifically what all those things are. In real life, all of those things take place in different rooms because they're whole operations unto themselves. So here is a pathology lab. You can see it's divided up into many different spaces, and the accessioning is usually one room. The grossing is where we do perform the gross description, and specimen cutting is a separate room. Tissue processing, which I will show you in detail, is a separate place. Staining, and then issuing here. Okay, so let's look at that in a little more detail. That's the overview. When the specimens come up from the operating room, we said that each tissue specimen gets a special pathology case number, and here's a picture of the Mount Sinai Pathology Lab, but here are some of the cases coming up from there, and here's Judith. She's our accessioner, and she's giving us a smile. She makes sure that every case gets a number, and if one patient has several specimens, that they're assigned to that same pathology number to that patient. If you have more than one specimen, they'll each get the same pathology number, but the first jar will get A, and then the second jar would be B, the third jar would be C, for example. All right, after they get a case number, they go to what we call our grossing room. And they're either a pathologist assistant, or a house staff, a resident, or a fellow will process the tissue according to specific written protocols under the guidance of the service pathologist. So here's an example of a physician assistant who will be describing the tissue and then will be performing specific cuts of the tissue for microscopy. Okay, as I said, there's specific protocols for handling all different types of tissues so that we make sure they're done in a way that provides the optimal information for your doctor. So in the grossing room, they do what's called specimen preparation. And as you could see here, this physician assistant has cut a few pieces out from the sample, and notice she's placing them with a forceps into this plastic device called a cassette. And here are some pictures of cassettes. Notice what they are. They're little plastic containers that can snap closed. Here's the top, here's the bottom, and you can just flip this. Once you put the tissue inside, you can flip this, and it fastens very nicely here. It snaps shut. And notice it has a lot of little slits in it, or little holes, that will allow chemical solutions to flow in to fix the tissue. Okay, so every tissue coming up from the operating room is handled according to written protocols, and from those tissues we cut specific tissue pieces out, or tissue sections. We place them into these plastic containers called cassettes. Okay, and these cassettes get labeled with a patient's pathology number that allows us to keep track of everybody, because these get batch processed with other patient cassettes, and so the numbering and the nice tight closure allows them to share the same chemical baths, if you will, without mixing up any tissues. Now, after the cassettes are generated, they have to get processed, and that is that in order to make a microscope slide, we have to be able to cut the tissue into a very thin section, 4 microns. And in order to do that, you have to make the tissue very stiff. Normally, tissues are very pliable. If you just pinch your skin, you'll see how soft and pliable your skin is. Well, we have to make that stiff so it can be cut with a special knife as a very thin, very ultra-thin section. So in order to make the tissue stiff, they have to go through some chemical procedures. And so we have these things called tissue processing machines, which you see a picture. Here's a few machines here in our lab at Mount Sinai, and you can see there are a lot of containers down here filled with different chemicals. Tissue processing machines contain a number of chemical solutions that are used to dehydrate the tissue and prepare it for subsequent paraffin wax infiltration. Tissue processors can handle roughly 300 cassettes at a time for what's called one run. Depending on the size and type of tissue, a run can last anywhere from 2 hours up to 12 hours, with the longer time needed for larger pieces of tissue. And what this translates into is that we can handle roughly 200 different patient samples per day. Now, after the tissues are run through the chemicals, exposed to the chemicals in the processor, they're taken out of the machine and they go to the so-called embedding station. And here you can see a lot of tissue cassettes. They're closed and containing the tissues. They've got their little patient labels and barcodes on them. And here we see a bunch of little metal trays, if you will. So at the embedding station, the tissues are infiltrated by liquid paraffin wax. So this is actually at a lot higher than 4. It's about 60 degrees, I think. So the paraffin wax is liquid, and the cassettes are opened up and placed into this little metal tray, and the paraffin wax is poured on top of it, and then placed on this area here, or in a little ice bath or room temp where the wax will harden up. When the wax hardens up, you've got your little tray with the tissue that's taken out of the cassette and put into the tray, and then the cassette is placed on the top, so the whole thing hardens. When you remove the little metal tray from underneath, you end up with your little cassette where on the back of it, you've got a little paraffin block with the tissue embedded in it. And that is the thing we called a tissue block. And I will show you what that looks like. All right, so here's the front side of the little cassette, and you can see the paraffin, the hardened paraffin is making it look kind of white. Okay, and here are the patient barcode and pathology number for this particular piece of tissue. All right, but the tissue's been taken out from the cassette. It's been opened up, and the lid has been taken off, and the tissue's been taken out and fixed, so to speak, onto the back, behind it, on the back of the cassette where you see the paraffin block. And it's basically from the mold of that little metal tray, if you will. Okay, so these are the paraffin blocks, and this is how we these things can be stored indefinitely at room temp in this form. We have special storage areas for these once we're finished diagnosing the case. All right, so we've got our wax block. Now, we still have to make that glass slide, don't we, for the pathologist? So then comes what's called microtomy. And in microtomy, notice here is our cassette, okay? And we've got here's the wax block facing toward the histotech, all right? And this is a special kind of machine that you can turn this little knob, and there's a little opening here that you place the block inside. It snaps shut on it and holds it tightly in place. And then this thing right here is a disposable and replaceable knife blade, this thing right here. Okay, so if you turn this notch here, this little area will open up and you can put in your blade to turn the notch and seal it. So you've got the knife blade here, and notice what you're going to be, there's a little handle you can use to advance to it. You rotate the handle and advances this arm here and puts the paraffin block in front of the knife blade, and you can generate these thin sections. This looks like paper thin. Literally it is. It's 4 microns. It's skinnier than paper thin. And you can see that we've got the paraffin outline here of the paraffin block, and then this little rectangular structure in here is actually the tissue. Okay, it has to be this thin so that the microscope light can go through it so we can see it, but without any special dyes right here, this would be invisible. Okay, so our histotech generates these ribbons, if you will, ribbons of tissue. All right, and then they generate them on this special device called the microtome. They cut these thin sections, as we mentioned, and then they'll take that ribbon with their hand, with their forceps, they'll put it in a little water bath, about a 30-degree or 35-degree water bath. And what happens is the paraffin wax will expand. We don't want any wrinkles in the tissue. We don't want any wrinkles to cover up any findings. So it expands the paraffin, makes it nice, and then the histotech will take a glass slide and capture a couple pieces that she likes best or he likes best onto this glass slide. Okay, the paraffin will just stick right onto the glass, and they'll take it off, and that will be ready for staining. The next step is they'll collect the slides onto a special slide holding rack, which holds about 10 slides, I think. And then we need to make the tissue colorful so that the pathologist will be able to see it when they put the slide under the microscope. So we have special staining machines, and here's a picture of one from the Mount Sinai Pathology Lab. They're called auto stainers. Again, you can see a lot of different chemical solutions. These are different dyes down here, and some wash solutions. Okay, and so we have these slide racks. The machine will hold up to 4 racks, and we said each rack holds about 10 slides. So in one run, the machine can process a total of 40 slides. If it's a big staging procedure, that might be just 1 patient case right there. If it's a little biopsy, that would be 40 patient slides then. Okay, so it could range anywhere from one patient to 40 patients. So we have more than 1 auto stainer, so we can process a lot of patient samples each day. The standard stain that we use in pathology is called HNE, which stands for hematoxylin and eosin stain, and the standard run for that is about an hour. The machine it contains an oven for drying the slides. We saw they were in a water, right? That ribbon was coming out of the water, and the slide gets wet and picking up the ribbon. So there's water, so we need to dry the slides first in an oven, and then the machine puts it through a set of different solutions. Usually for the H&E stain, it'll be some hematoxylin and eosin, then some alcohol washes, finally a xylene wash, and then the machine will put a little plastic cover slip on top with some special mounting medium to seal the tissue in between the glass slide and the cover slip and protect it so that when it gets handed out, it doesn't get scraped off the slide accidentally. All right, and here's a picture inside the machine. If we opened up the lid there, you can see some of the different dyes, and then these would be the ethanol, graduated ethanol concentrations here, and xylene. And here you could see some of the glass slides with patient labels on them here, the pathology number, okay, and you can see them sitting in a slide rack here. Now, after all that's done, the slides have to be organized. You want to make sure that if one patient has more than one slide, that they're all put together. And we also generate paperwork that goes for each patient's case. So that's where we move to the issuing section of the lab. And here's a picture of our area in Mount Sinai. These are pictures of the house staff and the tech staff so people can know who you're talking to. And here you can see a lot of slide trays, all right, and you can see that they contain, I didn't want to get too close because I didn't want to take a picture of anybody's name, so I kept it a little bit distant here, but you can see the trays have a lot of slides on them, and there are histotechs here who, some of them felt shy and didn't want me to take their picture, so I got her niece, but not her, okay, but she was still very friendly and happy to share her workspace. But you could see she's organizing the slides so that one patient, all the same slides from the same patient are on the same tray or set of trays, and then she'll match up the paperwork that goes with that. Okay, once everything's all matched up, the histotechs will put the trays in the appropriate boxes. So gynecology cases will go to the gynecology path section of pathology. For example, GI pathology will go into the GI pathologist's boxes. Okay, and it's always nice to connect the voice with the face. So this is a picture of myself in my office, and here's my trusty microscope. After the slide trays and paperwork are placed in the specific boxes, there will be, in teaching centers as we are, they'll be first looked at by house staff who are training, and they'll generate a provisional diagnosis, and then they will bring those to the board-certified pathologist who will look at all the slides, read what's on the paperwork, look at all the slides, examine everything, think about it, and then generate a pathology diagnosis, which is the written word that you see under the section that we mentioned called diagnosis. And so we call this generating the report or reporting. Okay, and again, we do that. We examine those stained slides under the microscope. And each tissue, pathology training allows us to look at the tissues to recognize the normal tissue and then to recognize disease in tissues. And that's what allows, after 4 or 5 years of training, allows us to look at the tissue and from what we see to write a pathology diagnosis. So again, here's a picture of what we saw in the beginning, the pathology report. And, you can look at your own report and get a sense. Basically, the doctor is looking for the report for these specific pieces of information. The report will tell your doctor, again, the specific type of cancer, if there is cancer, the specific name of the cancer, the distribution of the cancer, meaning whether it has spread, and if it has, how much it has spread. And that correlates with the stage of the cancer, which again, it's an indicator of the extent of the spread. And all that information is provided in the pathology report. just to give you a little flavor that the cancer type we mentioned, the name of the cancer, there are a lot of different types of ovarian cancers, if you will, what the layman calls ovarian cancer. There are about 40 different names that we could pick from. And I just wanted to show you what we would see under the microscope, just to give you a little flavor of what I'm talking about. These are 4 different kinds of ovarian cancer. This one here, it's labeled A on the upper left, is the most common kind of ovarian cancer, and that's called high-grade serous carcinoma. Okay, very much more. The second most common type is in slot D, the lower right. It's called endometrioid carcinoma, and 2 rare ones are the one on the upper right here is called clear cell carcinoma, and the one on the lower left here is low-grade serous carcinoma. So I just wanted to show you that they're given different names, and in fact, you can appreciate that they look different. They're different kind of tumors. They respond differently to different treatments. So that's why it's important to know. But I did want to give you a flavor that they actually look different, and that's what allows us, we learn how they look and we can give that name. So again, the most common one is this one, plate A, high-grade serous carcinoma. That's the name of tumors that look like that. Management plan. The pathology report provides your doctor with important information regarding the specific type of your cancer and its stage. The tumor type and the tumor stage have been the subject of much research, both basic science research and in clinical trials, and your doctor utilizes all this information to choose the best treatment plan for you. Tumor type and stage or extent of spread. The tumor type and the stage, again, are important in designing the management plan. And again, the management, there may be no need for any post-surgical treatment for low-grade, low-stage tumors, whereas in higher grade and higher stage tumors, you might need additional post-surgical treatment, like chemotherapy, for example. So we've sort of in a nutshell done our talk, and in summary, what we learned about during this talk was the components of the pathology report, how the pathology report is generated, and how your doctor uses the information in the pathology report in your management plan. And that's all I have to say. Thank you for your attention.
Great. Thank you so much. So now we'll have a little bit of a Q&A session. So I want to remind folks that are listening in that you can still submit questions. If you look on the GoToWebinar window, there's a drop-down for questions, and you can type in questions. Some folks submitted questions in advance, so I will start with those.
Okay.
We do have a few questions, so if I don't get through all the questions, please feel free to call the helpline, and a volunteer can speak with you, and maybe we can also reach out to Dr. Kalir to find out those answers.
Yeah, I was going to say, if I may say, if something occurs to you after the fact and you say, gee, I wish I'd thought about it at the time, if you get a after the fact question, do forward feed them in, and I'll try and provide some written answers for you. Okay, yep. So don't hesitate.
Great. Okay, so the first question submitted we have here is, how long do the slides last if they are needed for later review?
Okay, the slides, there's actually a law about that we have to, they last for years and years and years, and we actually have to hold on to them for about 20-25 years.
Okay.
We can't keep them forever because there's not enough room to keep all the slides, over decades and decades to keep them forever. There's just not enough room. So we'll hold on to them for as long as we can, and we're only required to hold on to them for about a quarter of a century, and then you're allowed to discard them. So that's pretty much where that stands at the moment.
Okay. And so somebody asked, what does it mean when an ovarian tumor has predominantly endometrioid features?
That's a good question, and it sounds like what they're saying is that from the pictures I showed you, that most of the tumor looks like the one on the lower right on that picture. That was that endometrioid carcinoma. Sometimes tumors are funny, and they don't. Not everybody's tumor fits the textbook description and looks like uniform throughout the whole tumor, like clearly one thing. Some tumors sort of fall in between, if you will, and they might have features that look a little like one thing and a little bit like something else. And when the pathologist says it has features, that's pretty much what they're trying to say over there, that it isn't a real clear any one of those that I showed you, but it looks mostly like the one they mentioned. Does that answer the question? I hope.
Yeah, that makes sense. So then, do you know, I don't know if this is in your wheelhouse, but do you know if how that would affect treatment decisions? Or maybe more on the oncology side?
I think it would be at the discretion of the doctor. Luckily, a lot of these tumors end up getting similar therapies. So that's that's the good news side of it, that whether it were one or the other, their first choice for therapies would be similar. So I wouldn't worry about that necessarily saying, oh, that's going to detract from my ability to get the best therapy. I don't think so. It's helpful for the doctor to have a name in mind so that they know which set of therapies they want to go with and what kind of duration of therapy they want to give. So the names are helpful. It's also helpful for them to know, though, if it doesn't look exactly like, a slam dunk, across the board, clear cut entity X, but maybe sort of looks like an X. I think the inclination would be to go for the same chemotherapy plan with both of those. So I think you're safe. Does that seem like a good answer? Did it make sense?
That makes sense.
Those are hard questions. Those are hard. They're good. They're good questions. They're hard questions.
Yeah. So somebody else is asking, how does this process that you're talking about compare to what is done at a smaller hospital?
The components are the same. If it's a smaller hospital, the only difference is that they might not have a specialist, and they might, instead of having those big fancy high volume machines, they might have smaller machines. And actually the auto stainer that I showed you, in the old days, all that stuff was done manually by histotechs. Okay, so that's staining bins that I showed you. Somebody would take a rack of slides, hold it in their hand, and then there's a certain amount of minutes you need to hold them in the dyes for each dye and wash. They would do all that manually and put it in the oven, a little separate oven, take it out of the oven, manually go through all the stains with holding the rack in their hand, and then when they're done, the thing I told you about that was cover slipping can be done manually as well. We do it occasionally when we're doing a rapid diagnosis. So in a smaller hospital, if it's not really cost effective for them to have a specialist, to have these big high volume machines, they may have a general pathologist. They'll be board certified too, but they may be a general pathologist and not a specialist. And instead of having all those big fancy machines, they might be doing more of that stuff manually.
Okay.
But it's the same. The output should be the same. In other words, you're still getting the hematoxylin eosin slides. It's the same kind of steps they would follow, right? You still get everything I told you would still be followed. It's just that instead of the big machines, you might not have that. Instead of a PA, if it's a really small hospital, you might just have one pathologist who's doing both the tissue processing, the grossing procedure, and then the microscope procedure and generating the report. But everything is the same. Does that make sense?
Right. Yes.
Okay.
Yeah. Okay. Somebody's asking about a terminology that they saw. They're saying, what is AJCC?
Oh, okay. Yeah, that's a special kind of staging, and AJCC stands for American Joint Committee on Cancer, and they have generated the staging manual. So when do you remember on the diagnosis part, I was telling you sometimes at the end of the diagnosis you'll get the summary, a little summary. That's the AJCC staging, and that's actually published so that we all use the same, across the nation, we use the exact same staging protocol, everybody. So after we're done making our diagnoses, we'll assign a stage to the cancer based on, the kind of cancer and then the extent of spread. And just to make sure we're all on the same page, we're all using the same staging protocol, and that's the AJCC. Again, that stands for American Joint Committee on Cancer.
Okay. So somebody's asking about a pathology report that's done on acidic fluid versus solid tumor. Do you know what they're referring to? Do you know if it's done on acidic fluid, does it also need to be done on the solid tumor? Does that make sense?
Is that their question? Is their question, if it's done on the one, does it have to be done on the other? Or is the question, what is it? Like, what does that mean? Or should I just answer them both?
They're asking the latter. If they're saying theirs was done on acidic fluid, and they're wondering should it also have been done on solid tumor.
Okay, and the answer is it depends on how much information they were able to get off the acidic fluid. So if the acidic fluid had a good number of well-preserved tumor cells in it, then there's a good chance that they would have been able to get enough cells and enough good material to stain it up and come up with the diagnosis they need to move forward. Sometimes acidic fluid, so the answer to that is maybe. Sometimes yes, sometimes no. So the first scenario is, again, if it's got a good amount of cells in it and they're well preserved, the cytopathologist may be able to render the name of the cancer just from that. And then your doctor can move forward with that information. Okay. Sometimes, though, the acidic fluid may not have a good amount of viable cells in it, and so they may not be able to know what kind of cancer it is, or they may have some questions about it. And if that's the case, that's when they would want to go to take another sample in maybe a different manner, like maybe a needle biopsy or something. So, I mean, sometimes it can work and sometimes it might not work. It depends on they have to try and see if they get a good yield. Does that answer that question?
Yes.
Okay, good.
And they sort of put in a follow-up here, and I'm wondering if this is part of your pathology study or not. So they're saying that the specimen also was shown to be positive for things like P53, CK7, and negative for other things like CK20. Is that part of the pathology report? And
yes, right. That's what so when they're working things up, we didn't really go into that. That's special staining, and I didn't really go into that because I thought that was a little more advanced. But that also is part of pathology, and that's when, if you're getting a sample and by looking at it on the standard stain, the hematoxylin eosin stain, if we can't be 100% sure about it, we have a whole battery of what we call extra stains or special stains that we can do. And all those names that you mentioned, the P53, the CK7, those are all special stains that we use when we're working up a tumor. And each one of those stains and combinations of them, whether they positive or negative, will characterize a specific kind of lesion, whether it's a malignancy or benign, and if it's malignant, where it might have come from. So we use those combinations of markers to help us to try to pinpoint, if we're talking about a few cells and let's say nobody's sure where did they come from, we can use all those special stains to help us to help answer that question. So yes, those are all pathology stains, and we do those when we need to, further investigate things if they're not clear from our standard staining.
Okay. So somebody's wondering about in the case of a recurrence, does the pathology report need to be done again, or can the old slides be reviewed?
Okay, yeah. So for a recurrence, they'll usually take a sample just to make sure that the thing that you're thinking is a recurrence really is a recurrence. And what we'll do there is we'll take a look at it. So it varies in patients. In some patients, the recurrences look exactly like, when we look at these, we'll have the patient's history at hand. We can look at their medical record to see what did they have before. So when we look at the recurrences, we know what they had before. We'll take a look at the recurrence, and sometimes it's a splitting image of the original. So then we can just sign it out as, malignant, whatever it is, consistent with a recurrence from the original ovarian tumor. Sometimes the recurrences can look different. And in that case, if it doesn't resemble the original tumor, we have to do those special stains. We'd have to do those special stains to work it up to see if, is this an offshoot from the original, or is this maybe something new? Okay, that's when we do some special stains. And sometimes if the patient's had a couple of different malignancies, and there's a recurrence, we might have to stain it to see, well, which one was it? So, for example, if somebody had breast cancer, and let's say they also had ovarian cancer, and then they end up having, let's say, a metastasis found in their liver, let's just say for just argument's sake, in that case, we probably would stain it up just to see if it looks like it's staining as a breast type of cancer or as an ovary type of cancer. So the answer to recurrences is sometimes they look like the splitting image of the original tumor, and then we can just make that diagnosis right up front by looking at the recurrence. If it looks kind of odd, we can always get the original tumor and compare it. We can do that. We can also use these special stains to help us tease apart and try to figure out, find the truth. What is this really?
Okay.
Does that make sense to you?
Yes. Yeah,
okay.
Yeah. That's a good answer. So some folks are asking about second opinions. When do you think it's a good idea to get a second opinion, or do you think it's a good idea to get a second pathology opinion?
So a lot of times it works like this. If you're looking for a doctor and you're going from one hospital to another, if you had a procedure done at one hospital and you end up going for, let's say, your definitive treatment at a different hospital, so by law or mandated by hospital boards, it's recommended that those original slides are at least reviewed by the new hospital staff, and that would be their pathology department. So that's one thing that happens. So that's like a legal kind of thing that is a second opinion. There are other ways to get a second opinion. Sometimes a doctor might, if the diagnosis doesn't jive with what they're thinking clinically, they may want to get another opinion from a pathologist that they know well, their own pathologist. On the other hand, if you as a patient don't feel right about what you're being told, that's always recommended that you have the right to go in and seek someone else's opinion. So, it doesn't have to be cancer. It can be a biopsy you had for something else. If you're not comfortable with your diagnosis, you can always, ask to have it reviewed by somebody else. That's okay to do, and that's your right.
Okay.
So there's no hard and fast rules about it, is what I'm trying to say. It's more, if somebody feels they want to do it, then they could do it. But there are no specific rules about it.
Okay, yeah, that's good advice. One person was mentioning that they are, like you said, they're thinking like there's something that they have heard on their pathology report doesn't seem to be like she says hasn't demonstrated itself so far. So she's wondering A, what is done to prevent errors in pathology, and what should patients do if they think maybe there has been a mistake?
Oh, if they think there's a mistake, if it doesn't, yeah, if something doesn't jive, and they should probably try to get another opinion about it. Definitely, if you don't feel right about something, you can seek another opinion. And patients, if you have no idea how to go about it, you can talk to your doctor or one of the doctors that you trust to help you with that.
Mm-hmm. Okay. Um, so let's see. We still have several more questions and not much time, so I'm going to see if I can.
Okay. Am I taking too long to answer them? I'm trying to give you a good answer.
You really got a lot of
I'm
questions.
trying to be helpful. Yeah.
So one person asks, what does it mean when an area or tumor is disrupted? I don't know if that's even within your realm.
If they said it's disrupted, is that what you
Mm-hmm.
said?
Yeah.
Yeah. Sometimes it doesn't necessarily mean something significant unless it's a stage 1 tumor, okay? So a lot of times when tumors grow, they might rupture kind of, or they might get stuck onto organ as they're growing into tissue structures that are near them. And sometimes when the surgeon goes in, they'll notice before they do anything, the tumor might have already have been spontaneously ruptured, and that's one form of disruption. Another form of disruption is sometimes during surgery, if it's a really big, delicate cyst, sometimes in the process of trying to remove it, even though they're being careful, it might break, and that's another form of disruption. They'll clean it up. It hasn't been shown that that causes any adverse effect on the patient. But in stage 1, disruption is important when you have a stage 1 tumor, which means when your tumor is confined to your ovary. Because the disruption, it'll still be a stage 1 tumor, but instead of being a 1A, it'll be a little bit of a higher letter, so it'll be a 1C. So if it's disrupted, it will change a little bit. It'll a little bit change the stage of your tumor. I think that's the short answer to that question.
Okay. And how much tissue is sent to pathology after ovarian cancer surgery, and how much of it is analyzed?
Say that first part again. How much what?
How much tissue is sent to pathology?
Oh, okay. Everything that's removed in the OR has to go to pathology. Everything.
Mm-hmm.
So all your tissue goes to pathology. And as I said, there are specific protocols. So you might be thinking, well, geez, what if somebody has a tumor that's 20 centimeters? We can't put that all through because we'd go bankrupt if we try to. There would be millions of slides. So again, our protocols are: if you have a really big tumor, like a 20 centimeter tumor, we serial section through it, and then we'll look for the different looking areas, and we'll sample from those. But we're required to take a minimum of 20 different sections. So one section per centimeter of tumor. Okay, so for a 20 centimeter tumor, it would be 20 different sections we have to take at a minimum. Okay, so we have specific protocols for how to handle. So you don't have to worry about, are they sampling it enough? We have specific protocols. So a big piece of omentum, which can be, again, 30 centimeters. If we want to look for microscopic tumor there, we will sample 30. Again, it's one section per centimeter. We'll sample a minimum of 30 different spots on it. If it, we'll palpate it. We'll look for suspicious areas which would feel firm. And if we don't find anything like that, of course, if we did, we would sample that. But if we didn't, let's say in the whole omentum looked totally normal, then we would go and take 30 different little samplings from it to look for microscopic cancer. So we try to be very careful and handle your specimens very carefully to try to make sure that we get the correct and an accurate diagnosis for you.
Okay. Well, thank you so much for your time. I think we've got to wrap up now. We've gotten to the end of our time. And maybe I will email a few more of these questions to you.
Sure.
Yeah. Thank you so much. We will.
Okay. I hope it was helpful to everybody.
Yes, definitely. This has been very informative. And we're
great.
This has been recorded, and we're going to put it up on the website, and we'll email out to everybody. I know a few folks joined us late, so if you want to go back and see the beginning of the presentation, that recording will be emailed out in a couple weeks, in 1 or 2 weeks, and also will be available on the website. And I can also email out the answer to some of the questions that were not yet answered. Also, feel free to call us on the SHARE helpline if you'd like to speak to a trained survivor. Yeah, that's at 1-844-ASK-SHARE. Well, thank you again, Dr. Kalir, for all your expertise. And thank you all for joining us and submitting your questions.
Okay, bye-bye.
Bye.